Well, as he mentioned, I'm going to talk a little bit about what's occurred in not only at Stanford, but in the U.S. overall in the last 15 years when it comes to obesity management. And I think it's interesting to kind of go back in time and see, what was going on, 15 years ago in 2003. There were really only two types of cases, the gastric bypass and the VBG. We had one medication that was approved. There were no FDA-approved devices. There was no accreditation for hospitals, and there were only about 15 fellowships. And if we look now, in current state, 2008, there's a full-fledged of different types of procedures, the band, the sleeve, the bypass, duodenal switch. There are now 5 FDA-approved medications, and they all occurred in the last couple of years. In addition, there's now 5 devices. Most of these are the balloons that I'll show you a little bit about in just a little while. And now we have over 800 hospitals that are accredited for bariatric surgery. So it's been a pretty big change in when you look at medicine, a short period of time, 15 years. In fact, you can say that we were kind of present at the creation of a new paradigm for healthcare delivery because all these things did not exist 15 years ago. Oh, and 57 fellowships. One thing that people have often wondered about is, have we peaked, when it comes to bariatric surgery? Ed Livingston, who was here for Grand Rounds not too long ago, wrote this paper, I think it was about 10 years ago, saying the bariatric surgery has plateaued, it's peaked, it's not going any further. And they reached this conclusion way back in 2003. So that's exactly when I started here. And so obviously I wanted it not to peak in 2003. I wanted to continue to increase. The one big change that did occur over time was the rate of laparoscopy. And you can see here that quite a few cases were being done open just about 20 years ago. Now very, very few cases are done open. It's actually down to about less than 5% nationwide. Now remember that prediction about whether or not we were going to peak, back in 2003 when it was roughly about 60,000 cases. Well, we're now in 2016, we've got our latest data, and you can see there that we're far from peaked. We're continuing to grow. It's now probably at the rate of about 10% a year, and so it's over 200,000 cases annually. The one other thing that you can see there is that there's been a big change in the type of procedure. The bypass, as you can see here, originally was a pretty big component and it's steadily declined. The band has pretty much died. It went from being a third of cases now to being less than probably 1% at most recent estimate. It's the sleeve that's really coming up, and it's a procedure that has really kind of led the growth. More invasive procedures like duodenal switch and things like that simply have not grown. They have remained pretty low. The other thing that's grown has been around revisions. And revisions indicate a couple of things to us. One is we have to be as appropriate as possible in choosing the operations. And second of all, obesity is a chronic disease. So you're going to see some ebbs and flows to people's weight, and we have to find different solutions for them. You can see there very easily at the bottom that the balloons are really increasing over time. And here you can see those trends in a different way. And you can see that green are the increases and red are the decreases. The bottom really fell out, like I said, when it came to the band. It's almost all gone. And the huge increase has been in the sleeve, 346%. So we're seeing all of these changes occur in a pretty short amount of time. So what's happened at Stanford, since 2003? And you can see here that we've collectively treated close to 3,700 patients, and we have a grand total of 126,000 pounds lost. And you can see there that the different procedures have different outcomes. Bypass gives you the most weight loss, followed by the sleeve, followed by the band. The anti-diabetic effect that we're all aware of with bariatric surgery is very well represented here. And the other thing we can see is that we've learned over time. This looks at our readmission rates and complication rates over time, and we've declined both of them. Our major complication rate now is less than 2%. If you look at the changes in procedures performed at Stanford, they do mirror to a large degree what we've seen nationally. And you can see here that the dark is a gastric bypass, and like you might expect back in 2003, that's pretty much all we were doing. You can see it's declined, and the yellow here is the sleeve, so you've seen that really gone up as well. The other thing that's coming up is obviously the balloons and our revisions. These are the relative contributions from all of our faculty over the years, which I'm grateful to for all the efforts they put forward in making the program as successful as it has been. And you can see this has been what's occurred over the last 15 years. Of course, Dr. Lau, Dr. Rivas, and Dr. Azaguri didn't join the faculty until a few years ago. So you can see there the numbers that we've had over the years. You can also see here that at Stanford we've seen more and more of these sleeve gastrectomies increase. And as you see that, it calls into question, is this always the right operation for patients? I see Mark Melcher, and he sends his patients for transplant to get them prepared. You guys can't list those patients until they've got a BMI under 35. We've learned a lot of lessons about what's the right operation for those transplant patients. It's not a bypass because it can lead to oxalate stones with those patients. It's a sleeve. So in that circumstance, the sleeve's the right operation. The one thing I can say, though, a sleeve doesn't always fit, and this is some work that Dan Azaguri and I did looking at the outcomes are differential based on the type of procedure. Band and sleeve, as you can see there, do have a different outcome. You can see it better here with kind of a distribution curve, and you don't see a classic bell-shaped curve in the middle there, and that's for the sleeve. And you can see it's even worse with the band. On the other hand, if you look at the bypass, its weight loss outcomes are pretty tightly packed, kind of what you'd expect. And then if we break it down in a different direction, you can see here that the amount of weight loss in a meaningful manner is almost always achieved by a bypass. And you can see that there. With a bypass, you're going to get at least that 50% weight loss about 87% of the time, as opposed to the sleeve, it's only about 60. So as a result, we've altered what we do in terms of our patients. So if you have a BMI over 50 and you have bad acid reflux, or if you have bad diabetes, those are patients who are going to get a bypass rather than a sleeve. You can see here what's happened to our severity of illness, if you will, for patients. Our BMI has steadily gone up over the last few years, and now we're approaching an average BMI of 50. The weight loss has still remained roughly to a decline of about 20 points to a BMI down to 30. Now our complication rates, these are the ones at Stanford. You can see when the program got started, the complication rates were higher. These are actual numbers, not percents. And you can see there that the leak rate has always remained pretty low. That's something that we're blessed with in bariatric surgery. I think having good blood supply in the stomach certainly makes a big difference. The other thing you can see here is that we haven't had a leak actually in the last couple of years. We have had mortalities, but if you look at this list of mortalities, again, out of roughly the 3,700 patients, we've only had one that was within 30 days. That's a good record that we're all proud of. If we look at why some of these patients passed away later on, it's related to oftentimes issues with substance abuse or suicide, indicating the need for these patients to have adequate social support, as you can see there from the different causes. The other thing that's happened over time, as Electron alluded to, is Stanford's been prominent in the national conversation around obesity, and you can see the different committee leadership represented there, including Omero Rivas and Janie Pratt and Dan Azaguri and Dan Eisenberg. Dan, I think you're co-chair now, right? So congratulations. And Jim Lau is on education, and Matthias is on adolescence. So I try to pack the court as much as we can and get as many people onto the committees there. We've had some good experience when it comes to teaching, both when it comes to our medical students as well as our residents through all of Jim Lau's effort. And again, we've had some recognition around national leadership through the presidency and through the college, as well as an obesity summit, which I'll go over in just a moment with you. We've been recognized for clinical efforts, both through top doctors, Dr. Rivas and myself were made honorary members of Brazil's College of Surgeons. Dr. Brodsky will like that. Brazil actually has the second largest bariatric surgery experience in the world. And it underscores how this is truly an international disease, not a U.S. disease. It's truly a disease of affluence. Research-wise, I think we've been pretty well represented. We've averaged a little over 10 articles a year, and we've had about 11 grants. 6 of them were FDA pivotal grants for some of these devices. And indicating the ecumenical nature of bariatric surgery, we've worked with just about everybody, including plastic surgery around stem cells and the differential representation through visceral versus abdominal wall fat. And we have some work we've done with psychiatry as well as economics, and plenty of research awards. So where are we with access, care, and effectiveness in obesity management? I think first of all, there's been a lot of myths out there. There's been a lot of opinions, but we have to focus in on outcomes. I think there was always that belief that it was risky. There's also a belief that, you know, it's patients' issue, that it's something that they should be taking care of, not medicine. And finally, you know, there needs to be grounded evidence, not gossip, not things that are just passed around, but things that actually have some evidence behind them. And I want to point out, this is not anything unique to bariatric surgery. If you guys are English majors, you might know about Susan Sontag. She wrote a great book called Illness as Metaphor. And, you know, Jeff Norton can comment on it, you know, many, many years ago in the 70s. Not that you're the only one that can comment about many, many years ago. But there was such a belief that there was a cancer personality. You know, there were certain types of personality types that attracted cancer. And what it showed, what she illustrated very nicely in this book, was that it actually, that kind of attitudes around treatment, around the disease process, actually inhibits people from seeking care. Sound like something we know, like around obesity, where people are sometimes thought of not trying hard enough or not having the best attitude about losing weight. And we actually see that represented here, and this was in a bioethics paper that came out. And it's strange that this would even come up. You know, when it comes to treatment, there ought to be an embrace of what the different options are out there. And I think part of the reason for the issue is we simply don't understand the disease well enough. And this is a really good article by a writer from the New York Times, and she wrote about, do you have to be superhuman to lose weight on your own? And I think, you know, she raised these issues a few years ago, but she really kind of anticipated this article. And this article, I thought, was really telling about the impact that attitude or motivation has when it comes to losing weight. And this is the so-called Biggest Loser study. I don't know if you guys have seen that show. It actually was supposed to be on the air last year, and it didn't go on the air because of some of the issues that were unresolved around this. Apparently some of those contestants were getting pep pills, phentermine, unbeknownst, and so there's been some investigation over what's been going on. But what's really important here is that it showed that all of those participants in those shows, every single one of them regained their weight afterwards, every single one of them. And so I think that puts to rest, this is not around attitude or motivation. You have to be pretty motivated to show up on national TV and be humiliated on a weekly basis. So everybody in that show wanted to lose weight, but as you can see here, they couldn't, especially long-term. Only one of those patients was able to lose weight long-term, and that patient had bariatric surgery, as you can see there. So why is it? Well, one of the reasons for it is that there is a biological component to this, not a psychological component. And again, we're scientists, we need to examine what the actual physiology is. And this is ghrelin. This is one of the many different hormones that help regulate our weight. And this is what prompts us to eat. You can see the peaks correspond to breakfast, lunch, and dinner. You can see the white dots are before people diet, and the black dots are after. Anybody in this room ever diet? I'm the only one? Okay, there's a few. So if you've ever dieted and you've lost weight, have you ever regained it and then a little bit more? Well, here's part of the reason. The body's not stupid. It will do everything in its power to recalibrate, and it's going to try to regain that weight and get back not only to that set point, but then beyond. And that's what happens exactly here with ghrelin. I'm going to show you just a short clip here about really hopefully understanding what's going on with some of our patients.
Ron had this gastric bypass, and it obviously worked for him. But it may not work for everybody. What should people know in terms of that surgery?
Well, first of all, I want to congratulate Ron on taking that step forward, because it takes a lot of courage to come forward and do something about your health. And this is a serious operation, but desperate times call for desperate measures. In a lot of ways, surgery is kind of the first responder to this public health epidemic. We have potentially 12 million patients who may benefit from this surgery. And in short,
So I think it's actually up to 20 million now. And does anybody recognize this guy? Nobody's a fan of movies? Anybody ever watch Varsity Blues? Billy Bob? Okay. So you can see there what happened to him, and he said that he actually had more trouble after he lost weight than before because people wanted him to be heavy for these roles. And you can see there, and he did extremely well for many years, but Ron had an addiction problem and actually passed away from an overdose. So again, it shows, like, you know, there's got to be understanding around the disease. And if you have better understanding around it, you can advocate better for it. And as you can see here, when it comes to advocacy, bariatric surgery has been kind of on the front lines for this because we know that healthcare is becoming more regulated. It's harder and harder to get coverage for different things. Last one in is the one that's always got the toughest battle. And like I said, bariatric surgery has been there on the front lines. We're starting to see it in other areas, you know, when it comes to co-pays. Our colleagues in orthopedic surgery, I know Derek Amatula can speak to that, you know, that's become harder and harder to get some of these elective cases done. But if you have acceptance of the disease and you can prove that what you do actually works, then you can hopefully advance the cause. And one of the things we did to help advance the cause is created state chapters for all of the ASMBS local organizations. So every single state was represented by a chapter, recognizing that all healthcare is ultimately local. It's hard to get a universal decision across the board unless you're Medicare. So we utilized all the different native talent around the country to help advocate for coverage. And remember, I mentioned the sleeve, now the most common operation that we do. It's now close to 70% of the cases. Well, just 6 years ago, it was not covered by bariatric by CMS. And as you guys know, CMS helps lead the discussion when it comes to access. If CMS sneezes, the rest of the insurance companies get a cold. It has that kind of influence. And you can see there that in 2012, not a single state covered it. And it was a big uphill battle. And it's actually kind of an interesting story. It was a single patient's complaint that led to coverage. She wanted actually to have a kidney transplant, and she did not want to have a bypass, and said, why can't I have a sleeve? And so from that it started, from a single patient. And obviously there was a lot of discussion. We actually had evidence. That's where having a registry is extremely powerful. We were able to present some of that data. And we also bound together with different organizations. We had about half a dozen sign on. And then in about a year or 2 years, we actually got all of the entire country covered for the sleeve, and now it's uniformly covered. But it shows why it's important, as physician surgeons, to be involved in health policy, because if you're not, you're going to be part of that discussion. To that end, we started a political action committee, and every year we have a reception wherever our annual meeting is, so that way we collect a few senators along the way. This is Bill Cassidy from Louisiana. We're non-denominational. We go across both sides of the aisle. What we're interested in is our patients having the best access to care. The other thing that we have to do when it comes to advocacy is really make a value equation for what we do. And if you look here, this shows as cost goes up, it's very directly correlated to BMI. And so if we spend all this money already on obesity, wouldn't it make sense to spend it on its treatment? So maybe we can prevent some of the downstream cost. And we kind of saw that natural experiment take place here. And this is from the Truvin database, biggest all-payer database in the United States. And you can see here that the green represents people that had gastric bypass surgery, and it actually decreased cost over time. The patients who did not have surgery, you can see, increased over time, as well as those patients who never had surgery. The other thing when it comes to advocating for coverage is effectiveness. So this is a very nice study that demonstrated long-term survival benefit for bariatric surgery at 5 years, and you can see that represented here. It's an overall reduction of 40%, which is pretty huge. I know in oncologic literature, if you're able to get a 5–10% difference in survival, that's noteworthy. So to see this is pretty eye-opening. These were 5-year data. We actually now have 12-year data, so this actually holds up over time. But we have to be honest about our results, and see what we can see where there's a difference. And you can see there that at the bottom, there were a couple of places where mortality actually went up. And it was around suicides, and it was around accidents. And I think the one thing that binds those two things together is likely alcohol. And that's what was represented in our mortality data at Stanford. So I'll show you one other clip here.
The demand for weight loss surgery is booming in the United States. 140,000 procedures are done each year. But following surgery, doctors and patients have reported an intoxicating observation.
People report they feel tipsier quicker after gastric bypass surgery.
So there was a belief that, patients when they lost weight, they were going to transfer their addiction from food to alcohol or other things. In fact, that's what you see there, the addiction transfer. So again, it was a psychological perspective that came forward for these patients, when actually it was physiologic. And we know that the receptor that helps metabolize alcohol dehydrogenase, is in 2 places. It's in the stomach and it's in the liver. So if you rob it of its first pass, it's naturally going to alter its alcohol metabolism. And you can see that's certainly what happened with the bypass. This is a study that I literally funded out of my pocket. I had a patient who said, does this really happen? Does our alcohol metabolism change? And I said, I don't know, let's look it up. There weren't any data around it. So we got the idea of buying a breathalyzer and a box of wine. And that was the whole study. And so that's where we started, and we ended up doing the study, and it got a lot of notoriety. My favorite headline was "Trading Twinkies for Tequila." That was the best one. But what we did is we recruited patients to have 5 ounces of red wine. We had no trouble recruiting patients, and we're able to get them to do the breathalyzer. And these were some of the results that we found. And this was strictly for the bypass. So before the operation, their breath alcohol level went up to 0.02. And then after surgery, the same patient, they were legally intoxicated. And again, this was for the bypass alone. So if we take it one step further, we did do it for the band and the sleeve. We did not see the same effect. And the reason we didn't is because it makes total sense. Those stomachs are largely still intact. And again, we looked at this as being a psychological issue when it actually was a physiologic issue. And here's a study I found recently from Japan that showed they do a lot of stomach surgery in Japan for the high rate of stomach cancer there. And what they found was that gastrectomy was a risk factor for alcoholism. So it wasn't unique to the obese population. What it was emblematic of the physiologic response. So we've got to have better understanding of what's going on. And to that end, my society and the National Opinion Research Center out of Chicago commissioned this survey, and we were trying to figure out what are the knowledge and attitudes around obesity in general. Well, people do view it as being a serious health concern, and they rank it right up there with cancer. But unfortunately, they don't make the connection about doing something about it. And I think the biggest problem is most of patients who come in don't talk to their doctors about their weight. They're embarrassed about it or don't feel that there's options available. And I'll point out we do have a lot of options available for folks. It's not all surgery. And one thing that we've tried to do is change the conversation around treatment and not keeping it just around bariatric surgery, but opening it up to all disciplines. And you can see here we were able to get together roughly about 35 different societies, including AMA and American Diabetes. And Derek represented the Orthopedic Society a couple of years ago, the last couple of years. And you can see there we had payers there as well. And one of the things we wanted to bring out of it was just to make sure we had the entire house of medicine working on this problem, because it can really create tremendous issues for us downstream. Increased cost, decreased effectiveness. What do you always hear at M&M? This patient was, BMI of 38. We had a lot of trouble doing that pelvic dissection. 38 would be little for me. So it's something that you got to consider with patients down the road, that weight does impact their outcomes. So we've done some outreach with these different societies, and we've actually had, I think now about altogether 5 different collaborative statements. This one is with occupational medicine. We're making a proposition to employers that it's in their best interest to treat obesity so they don't incur cost. We make the same sort of argument people used to make about insurance coverage, that people who aren't insured will seek care in the ED. So you're paying for it anyway, you're just paying for it in the most expensive way. We make the same argument. You're paying for the consequences of obesity. Why not pay for it up front? The other big society that's come on board has been ASCO, and I think some of you guys are members of it. It's 35,000 members strong for oncology, and they've recognized that obesity now will be the leading preventable cause of cancer beyond smoking in the next year. So it's a place that we're trying to make common cause with the orthopedic community. We've worked as well, and I'll show you a little more detail about that, a study that we're doing here at Stanford. And we've done some work with the National Lipid Association, and upcoming will be American Heart. Here's some of the data with ACOG showing the impact that weight can have on both fertility and adverse birth events. Again, what's really kind of neat about bariatric surgery is that you're able to work with a lot of different fields. It's not just weight loss, but it's also around its impact on different diseases. Certainly around diabetes, and you can see there Tracy McLaughlin, Sue Kim, and Marina Bassina. They've been great partners with us when it comes to working on patients who have diabetes. One of the interesting things here is how consistent the effect has been on diabetes when it comes to bariatric surgery, and it's roughly always about 82% remission at 1 year. We've actually gotten to the point now that we've introduced into the equation that potentially there could be coverage for BMIs 30 to 35 with diabetes. And one thing that's come up is really, how does this happen? Do we really know the mechanism for the resolution for diabetes? And the answer is not clearly. It's actually a weight-independent effect. It's not, for you guys who have been on service, you know that in a couple of weeks, these patients aren't taking insulin. And so it's independent of their weight loss. And we've done some studies to figure out what's going on. And one of them was around the microbiome, which has become pretty hot lately. But with Tim Sweeney, we looked at some of the changes that were represented in the literature, and it does seem to be that there are certain bacteria that bloom with weight loss. We took it one step further, and it's a kind of a lot of wording, but this is a metabolomic study, and at the end of the day, what we found was the bacteria change, but more importantly, the bile acids change. And if the bile acids change, then the receptors are signaled, and there's a specific one, TGR5, that turns on something called GLP-1. So for those of you who know what GLP-1 agonists are, this is exactly how you treat diabetes. So the end result for all this stuff may end up being the changes in the microbiome. Now this is, you can prove this through Koch's postulates. You can get the bacteria that you think lead to this change and introduce it. So more of that to come down the road. Here you can see it represented a different way, and its secondary bile acid metabolism is what really changes, not the primary. So again, that's where you kind of see the big differences. Here's some of our colleagues in pediatrics, Tom Robinson. Tom was the guy who figured out that the kids' meals, where they come with the toys, increase brand preference for the kids so much that they will take, you can take milk and put it in a McDonald's wrapper and then in a plain wrapper, and they will tell you that the taste of the milk in the McDonald's wrapper is so much better. And it's directly correlated to the number of TV sets in the room. That was Tom's work. Larry Hammer and Elizabeth Shepard, and we started the pediatric program at Packard about 14 years ago. So you can see here this was on Good Morning America.
Over the last few years, since 1997, we've actually seen a five-fold increase. You're welcome. You did it.
So that's one of our patients, and you can see it has a tremendous impact, on the physical appearance, but more importantly, the medical problems. Here's pseudotumor cerebri, and you can see there the black is the optic fields are being destroyed because of pressure in the brain, because it doesn't empty the way it should. And you can see here after surgery that some of those fields were restored. Now that being said, we've done some further studies with our adolescent patients comparing them to adults with the SF36, to see their quality of life. I want to point out one of them here because we actually saw a decrease for our adolescent patients. Their mental health scores actually went down after surgery. Everything else got better. The vitality, the physical part of it got better, but the mental part did not. We have to recognize that they're in development. They need a lot of support, and that's why, entertaining doing adolescent weight loss surgery is not for the faint of heart. It should be done, again, in a big-time collaborative manner so these patients don't fall through the cracks. We simply don't know enough about it, and we need to make sure they have the adequate support because bad things can happen. And you can see here that we've had some cases of teen pregnancy that was unintended, drug use. All of these things have occurred afterwards, and I call it social reentry. These patients are so socially isolated that when they lose the weight and people talk to them, they don't have the same coping skills. They fall into the wrong kind of crowds, and so it's an issue that comes up, and we have to help them with it. Talk a little bit about orthopedics. It's a big service, and it's one that certainly has impact when it comes to obesity. You can see Derek Emantula, Stuart Goodman, and Bill Maloney there. And we all know about the impact that obesity has on everything from diabetes to high blood pressure to sleep apnea. But there's one other place it has impact, and again, that's around complications. And if you're an overweight patient, your chance of keeping that joint decreases quite a bit. And Derek has written extensively around this topic. I think most of those joints are supposed to last for 30 years, but if you're obese, they only last for 10. And if you can see here, there's one of the reasons for it, is there's a lot of pressure that's extended when you carry weight, particularly going downstairs. It's like 3 times your body weight. It's an enormous amount. We actually did some studies with the Human Performance Lab here just to show some changes before and after bariatric surgery, and you can see there the arrows are kind of vector forces, and you can see how strong they are when patients are heavier and how it gets better when they lose weight. The other thing you can see there is the gait itself is abnormal in a patient who's extra weight. They have a varus malalignment where their knees are out, and all of that does get better after some of the weight loss that occurs. So we can see here that, again, carrying extra weight leads to more risk of infection. You can see that it also can lead, and here Derek's paper with revisions, so more costly. So what are we doing? Well, we're doing a study, and it's called the SWIFT trial. And what we're trying to do is figure out if weight loss can work as prehab. If patients can lose weight, they're going to be more mobile, their blood sugar is going to be better controlled, their high blood pressure is going to be less, and for all those reasons, it's something that we're looking forward to completing. And so thanks to Derek for helping lead that orthopedic study. So a little bit about cancer. I've already mentioned what we know is coming, that it's going to be taking over smoking. But the one thing is, what role does weight loss play in cancer treatment? Jeff has sent me a couple of patients that he didn't want to operate on right away because they were pretty big. I can remember a thyroid patient, Jeff, you remember her? She was like close to 500 pounds and just simply wouldn't be able to get the right kind of surgery. So we were able to operate on her, get her weight down, and able to get her operated on. I think those are extreme circumstances. I think where we're going to see the impact mostly is going to be around prevention of recurrence. And if you look especially at hormonally sensitive cancers like breast and like endometrial, they're already doing this study at Dana-Farber. And this study is just around kind of exercise and diet management. And we all know that that's minimal in its impact. So the idea is that we can do something better around bariatric surgery to prevent recurrence of breast cancer or endometrial cancer. Cardiology is certainly a place that we have a lot of close alignment with. Randy Vagelos and Mike Fowler, people we've worked with quite a bit around compensated heart failure patients. I always say that the way to the heart is through the stomach. And you can see here that certainly you have impact when it comes to some of the cardiac risk factors, huge declines in LDL and triglycerides, and very rare, you actually see an uptick in the good cholesterol, HDL. And these are long-term results, as you can see there, and they go out for over 7 years. And one thing that many hospitals, payers are struggling with is the enormous cost around treating heart failure. Some of the readmission rates, as you can see there, can be almost 50%, which is huge, and it costs so much money for these patients to come back in. And a lot of the home treatment programs have not quite worked out as well as people hoped. Now, there's one thing that seems like it might work, at least in this one study, showed that patients who had surgery versus those who didn't had less risk of readmissions for CHF. So maybe some more things coming when it comes to helping these patients. And this is a proposed study looking at the impact of bariatric surgery on heart failure treatment. But I'll go to the end here where we started, which was around patient safety, because that's where there was so much concern. This paper that was published now about 15 years ago pointed out how much variation there was in outcome when it came to bariatric surgery. In fact, if you look there, if patients were over 65 and the surgeon was doing less than 15 cases a year, that was a 21% mortality. Huge, huge variation. When this paper came out, it created a lot of discussion, especially around CMS. CMS said we are not going to cover this unless there is some sort of systematic approach. So a friend of mine, Bruce Wolf, and I wrote this editorial in response to those outcomes, and what we said was, if they go to the right places with the right hands, you're going to see improvements in the outcomes. And so that's what led to accreditation. And like I said before, we've had now over 800 hospitals that are accredited, and you've seen truly a big success story when it comes to the decrease in mortality. We went from mortality rate that was about 1 out of 100, and now it's about 1 out of 1,000. In fact, the impact it has here is international. Bueno, muy buenos días, y lo que tiene que hacer un paciente cuando está considerando tener esta cirugía, especialmente en Estados Unidos, ir a un hospital que tiene acreditación. That was for Dr. Rivas. But accreditation does matter, and you can see here that we've published studies with Dr. Azaguri showing that the impact of bariatric surgery and accreditation, it definitely makes a difference. We're now looking to do things beyond mortality. As you've heard before, it's already gone down to pretty low numbers. Again, out of 3,700 patients at Stanford, we've had one mortality within a 30-day period. So we're looking at new horizons, and one of them is obviously readmissions, because that's a place that has a lot of emphasis around cost. Bariatric surgery causes for readmission are frankly preventable about 2/3 of the time. They're usually about dietary indiscretions or taking the wrong kind of medications. It got our attention here because Health Net sent us a letter saying that if our readmission rate was above 5%, we would be disinvited from the network. So that certainly got our attention. So we put together a program, included a lot of patient education, videos, so the amount of education that a patient got was not dependent on our schedule or on our mood. It was they're going to get the same dose, so that helped out. The phone call when the patient gets discharged is probably the most important thing, though. And of course, giving them same-day appointments and using our infusion center where needed makes a difference. You can see there that we had pretty good reduction in readmissions, and we've actually been able to maintain that over time. A lot of quality is truly persistence. Another aspect of quality is really the team. When we introduced our dietitian as part of our post-op visit, we decreased our readmissions from 9 one year to none the next year. It underscores how important the discussion is around nutrition in that immediate post-op setting. We extended some of the lessons learned here locally, nationally, and we did a program called DROP. It was over 128 hospitals. What's interesting about the program is we never met in person. We did this all through the webinars as well as through a different checklist, and this is some of the readmission bundle that you can see there. Preoperatively, the educational video, making sure the patients had their prescriptions when they left the office so they didn't go searching for it after they were discharged. When they were inpatient, they met with the dietitian again. That's what I would call a teachable moment. You know, when you have incisions, all of a sudden, surgery is pretty real, and that's a good time to start talking again about what's expected around diet. And again, closing the loop post-operatively for patients was very important, calling them after they got discharged, and of course sending a letter to the referring doctor. What was the impact of the program? We can see here that it really picked up over time, In the first quarter, it actually went up, which is not unusual in quality improvement efforts. You'll see it get worse before it gets better, and it's really around standardization. And so what we saw there at the end in that last quarter was a reduction of 27% nationally. The other thing that we've tried to do is get to zero when it comes to SSIs. You know, Peter Provenos' work at Hopkins, getting to zero with line infections, and he was able to accomplish that at Hopkins. We were able, for a brief shining moment, have no wound infections for 1 year. We had one recently, so we had 1 year. So we'll keep at it, but it's all about being consistent in the OR. It's also about being consistent in taking care of the patient afterwards. We've also had a lot of recognition around our quality from our different payers, and it leads us to where we are currently around obesity care. A lot of the emphasis over the last 15 years has truly been around surgery, but I think the future is going to really be around a continuum of care, because right now we're treating less than 1% of patients who need therapy, so we need to come up with different solutions. That includes medications. It also includes things like endoscopic interventions like the intragastric balloon. To me, this is like the cardiology stent. It's not a medication, it's not a statin, it's not open heart surgery, it's something in between. And I think it's important for us to recognize how these therapies can work together. If we conceptualize that obesity is truly a disease, it has stages, just like cancer. And I'll tell you, when Dr. Ezaguri and I looked over some of the patients who didn't lose as much weight as we wanted them to, well, one of the things we found was those are patients who started out at a BMI over 50. And that's really, truly kind of disseminated obesity. It's hard to eradicate all on its own. So one thing we've always espoused is losing weight before surgery. And our goal was, frankly, just to avoid complication. If you can see there, when people gain weight, that's when they end up having more complications. And part of the reason is it swells the liver. And so when we're doing the case, it makes it harder to work. But the other thing that we've realized is if we're able to decrease that weight before surgery, it not only decreases complications, it enhances the long-term weight loss. And taking a page again from our oncologic colleagues, we're going to try to downstage the disease. We're going to try to do some preoperative chemotherapy for our patients beforehand. How are we going to do it? Well, we've now got, again, 5 different medications available to us to see if we can do that. And we're finishing up a trial in the next couple of months using it preoperatively, and this will be the first randomized trial of using pharmaceutical agents prior to surgery. We're going to see if it makes a difference. You can see here right away that it made a difference in the pre-op weight loss. We'll see if that advantage is extended long term. Now, what about balloons? What else is coming forward? I'll show you one last clip here.
Americans who are struggling to lose weight when diet and exercise alone aren't producing the results. It's a pill that's unlike any other out there because of what happens after they swallow it. Patients who take
It's called Ellipse. The balloon is in a large capsule with a thin tube attached that the patient swallows. Once in the stomach, the doctor fills the balloon with saline, creating a sense of fullness so patients eat less. After 4 months, it dissolves and passes out of the body.
We're at the dawn of a new age when it comes to obesity treatment.
34.
So the balloon is going to meet that need where a lot of patients aren't coming in. It's not meant to compete with surgery. It's really very straightforward, easily to place. We did a study looking at its post-approval performance, and we had a total of about 137 patients between the 4 different programs. And what we found was that the patients actually post-approval lost more weight. And I think part of that is we are being more consistent about the educational aspect of it, and we're using medications at the same time. So it's multimodality therapy. So I know all that sounds great, all the different things that have come forward, but are we truly making a difference? And this is just stuff I pulled over the last couple of weeks. If you get yourself on one of those obesity boards, you will get all this information. But you can see here that we're certainly not making big impact yet when it comes to obesity. And I think it's because of scale. We're only treating, again, 1% of affected populations. And most of the time, patients don't want to come in because they're not looking for surgery. So we have to get them in one way or another to get some sort of treatment. So I think the future is going to lie in different directions here. Whoops. Let's see what happened there. I think the PowerPoint stopped. Let's see. So I think the future is going to be around having all the different modalities available in a single center. And I'll show you that here. So I think having the metabolic centers, I think, recognizing that obesity is a family disease, so you treat both the entire family there, the parents as well as the kids. I think a network approach is going to make the biggest difference. It can't be just one clinic. It's got to be an entire population, different trials that come together, and increasing long-term follow-up. So this is hopefully what it'll kind of look like when you get everything working together. Lifestyle changes, as well as medications, as well as endoscopy. And there are very, very few places that are able to accomplish all of those different modalities. We're lucky we have all those capabilities here, so it's something that we can look forward to down the road to improving even further. The last thing I'll mention too is around the impact that it has not only on the individual patient but on the family. So you can hopefully have a halo effect. If you treat one patient, you don't treat just one patient. You end up treating that entire family. And that's something that was brought home in this study that showed that if you have friends or family who are obese, increases your risk of being obese. We wanted to see if the reverse was true, and that was a halo study. You can see husband and wife operated on them on the same day. I think Jay actually helped me with that case, those cases that day. You can see there they are with their kids, and here they are about a year later. So not only the parents lost weight, but the kids did as well. We've got other challenges, which is opioid use after bariatric surgery. We know that the naive use for opioids increases. It's not a lot, but it's definitely there. We have a program in place through MBS ACOEM called Energy that addresses hopefully opiate-free. They're as opiate-free as we can be surgery, so we can avoid some of those issues. I think one of our biggest issues is long-term follow-up and getting patients to come back into clinic, especially when they lose their insurance or they move. So we're looking for patient-reported outcomes to address that need. We're looking at technology to help us, and that is around these biometric scales, as you can see there. So you have to have your fingerprint or something like that. You can't put your kid on there or your dog and take credit for that weight. So that's what we're looking at for the future. That's going to help not only with getting those outcomes, but believe it or not, it actually helps with adherence. So it's actually a maintenance tool. We've talked to the insurance companies about covering this. So it's like a glucometer, but obviously for weight. Now, that's a lot of work over the last 15 years, and this work wouldn't have been accomplished without help. And especially want to start with the A's, and that's anesthesiology, and Harry Lemons and Jay Brodsky, who were absolutely instrumental. When I came here, I came from North Carolina, where we put A-lines in everybody, awake intubations, triple lumens, and both Harry and Jay have really pioneered anesthesia for the obese patient. The sniff position for intubation, all of those different innovations that they've come up with. And he got me on the nitrous oxide study. So he did a study that I was complaining that nitrous oxide was being used because there was too much air in the bowel. And of course, he showed that I was wrong in assessing that nitrous oxide was being used. And I also want to thank Subhash Banerjee, who's our go-to guy in gastroenterology. He's been outstanding. From administration, I mean, our quality efforts have truly been supported to the extreme by Roxanne Hyde, and certainly our business development models have been really supported by Sheila Tost over the years and Jane Shanahan, so thank you to you all. I want to thank the 18 fellows that we've trained over the last few years, and I want to welcome our latest fellow, this Michaela, who's going to be a fellow in about a year, so welcome, Michaela. All of our, okay, deserves a round of applause. We actually didn't even interview anybody. So I think that tells you something. We get about 80 applicants a year for one spot. So we think a lot of Michaela. She's going to do great. Think a lot about our residents who allow us to have such an enviable patient safety profile. This wouldn't have been possible without all the efforts that you guys do on every single night. Also want to thank our med scholars. If you're not familiar with the program, these are students who work with you to do research. And over about 12 years, we've had about 30 med scholars. And a lot of all the research you see there has been impacted by those med scholars, and couldn't have done this without all their help. Of course, our clinic that have been instrumental in helping meet the needs of our patients. It's a big team, as you can see there, but it's a team that works well together. Big time thank you to the following: Ralph Greco for #1 hiring me, so that was important. Jeff Norton for nurturing me, I appreciate it, Jeff. Sam So, who you guys may not see too often, but Sam gave a grand rounds a few years ago that really impressed me. Sam is a guy that goes from soup to nuts. He had everything in place in his program around liver cancer. He had community involvement, he had students, and I really took that to heart. I was, I guess, here only for about a year, and it occurred to me, like, this is great. I got to do what Sam does. So you can always learn from different people from, different walks of life and different fields. Because certainly I don't do a lot of liver cancer, but I learned a lot from him. The last guy, I don't know if you guys recognize him. Does anybody recognize him? You know him, huh? Jerry Reven. This is the father of Syndrome X, metabolic syndrome. And Jerry was inspirational to a lot of the research we did in bariatric surgery. Terrific guy. He was in his 80s, active as he could be, and he really wanted to participate in the studies and encouraged us to do even more. So he will be missed because he passed away recently. A big time thank you for my partner, Homero Rivas. He will be missed. He was absolutely critical in this program. Couldn't have done any of the things you've seen here without him. I'm going to miss him a lot. He's more than a partner. He's a friend. Please join me in giving him a round of applause. And lastly, I got to thank my family. As you can see there, my wife and my 6-month-old proofread all my papers before we get them published. And you can see why I'm bleary-eyed sometimes in the morning. So that's our baby boy, Jack. So thank you guys very much. You can see those were the first 15 years. Hopefully there'll be a lot more good things to come in the next 15 years. Thank you guys very much.